Way too many people are on the wrong statin. I'm going to share exactly how I decide which statin to use. The wrong approach can be deadly. If you're not treating cholesterol adequately, your arteries are clogging up. This is the key thing. Every 39 units you drop your LDL cholesterol, your chance of a deadly event goes down by 20 to 25%. That's huge. So in this video, we're going to go over which statins are the strongest and provide the most protection, which have what kinds of side effects, and I'll tell you how I like to choose between different statins because it depends on who the person is. I'm also personally on statins, and this has changed my life. I'm Dr. Omar. I'm here to empower you with evidence-based medical information. No gurus here, no fluff, just the facts. We know that the longer you have high cholesterol, the more your risk for heart disease goes up. Guidelines are now even saying, let's start checking people younger, get people to lower cholesterol even more, and be more rigorous about this because heart disease is the #1 killer in America. And about 80% of heart attacks are preventable. In picking the right statin, the key thing is that it's not about the brand. It's about the fit between you and the drug intensity, the specific drug, the risks and benefits. So we know statins work. The risk of a heart attack goes down by 33%, stroke 22%, and the chance of dying by 8%. Who wouldn't want that? The most updated guidelines recommend the LDL to be under 100 for most adults. But if you know that you have a greater than 10% risk of a heart attack or stroke in the next 10 years, you got to be under 70. Most people are not under 70. Most people get their cholesterol LDL checked and they're like 110, 120. They say, oh yeah, I don't have any chest pain, I'm fine. But that's not the best way we know. And if someone already has had some heart disease or even peripheral artery disease in their legs, the LDL should be under 55. That is pretty low. So these are the current benchmarks. Think about your last visit with your doctor. Where are you on this spectrum? So the first thing you need to consider is how intense is the treatment you're giving. Is it a high intensity, moderate intensity, or low intensity statin treatment? High intensity means your LDL went down by more than 50%, and low would be under 30%. So you have to think, am I actually using something of the right intensity at the right dose? So for example, Crestor Rosuvastatin is a high intensity statin, and you can go up to 40 milligrams, whereas Simvastatin is a low intensity statin. Maybe your doctor just kind of threw you on one of these. Maybe you saw a nurse practitioner or a physician assistant for 15 minutes and they just started you on something. They didn't really have an in-depth discussion with you. So you have to take responsibility for your health in your own hands, unfortunately, and think about these things very deeply. So think about intensity. For most people who are worried about their cholesterol, they're going to be needing high intensity treatment. And in that case, it's either going to be Crestor, Rosuvastatin, or Atorvastatin. These are both great options. The others are going to be moderate or low intensity options. Both of these medicines have been shown to save lives. Both of them are very effective for primary and secondary prevention. Primary prevention means before you've had any heart disease or heart attack. Secondary prevention is afterwards. So these are the two you probably have heard of. Atorvastatin is kind of everyone's default medication. It's the most studied medication. It's very flexible in its dosing. It's got a pretty good safety profile. So you might even be on this one already. Now, Crestor or Rosuvastatin, this is a much more powerful medication per milligram. So if you need a higher potency medication, this might be for you. And more importantly, it has lower drug interactions. So if you're on a lot of other medicines, your doctor might want you to be on this one instead because it has less interference with all the other medicines you might be on. The key thing though, in the end, is mortality. Does the medication change how long the person is going to live? When we look at randomized controlled trials, we don't see any difference in these statins in terms of mortality. And that's important to remember because you'll hear all kinds of claims. So what does matter when you're comparing these? Well, Atorvastatin has an overall better safety profile than Pravastatin, Simvastatin for secondary prevention. So if you've already had a heart attack, you have a stent in, Atorvastatin has a better safety profile. But there's no real difference for primary prevention if you haven't really had any cardiac events. For Crestor, there's one observational study, meaning like a cross-sectional study, that shows lower mortality with Crestor, but it's not a randomized controlled trial. So I don't take too much weight to that. We do see some signals of less liver issues on Rosuvastatin. So if someone has maybe some history of liver problems, I might think about Rosuvastatin for them. But Rosuvastatin has a little bit of a signal for higher risk of new onset diabetes. So that's something to keep in mind. Because pretty much everyone's at risk for diabetes, but it's not a huge signal. The key thing people worry about is what's changing in the heart vessels. And if you actually look at the volume of those plaques, we don't really see a difference if you compare Atorvastatin and Rosuvastatin, even though Rosuvastatin will drop your LDL even more. So no real difference in terms of the volume of those blockages. However, there are a lot of things you got to think about, and think about where you are along this bell curve of risk factors. So for example, if you're on an antifungal, you're going to need a lower dose of atorvastatin. You're going to need to avoid simvastatin, avoid lovastatin, and you want to probably be on rosuvastatin. So talk about that with your doctor. And certain antibiotics called macrolides. Persons of East Asian ancestry have a greater sensitivity to rosuvastatin, for example, so they need a lower dose. There are racial differences in metabolism of medications. If someone has kidney disease, they shouldn't have a rosuvastatin dose above 10 milligrams. Women, there's some studies showing women have a higher risk of muscle symptoms, myopathy on moderate intensity statins, but it doesn't really show up when we go to high intensity statins. So maybe if you're a woman, you might want to consider paying a little more attention to those moderate intensity statins. For example, you would be safer on Crestor. So let's assume you're interested in high intensity therapy. The first line is going to be atorvastatin and rosuvastatin. Rosuvastatin is going to reduce your LDL a little bit more, but probably no big difference in mortality. So not much of a difference there. And like I said, probably safer on your liver if you're going to go with rosuvastatin. If you're in a moderate intensity therapy, most people will prefer atorvastatin, as I do, over simvastatin because of drug interactions. Now, what about side effects of statins? This is what everyone's worried about. These are things I get questions about all the time. So muscle symptoms, myalgia, weakness, liver enzyme elevation, liver damage, and increased risk of diabetes. So maybe this is what's also on your mind when you think about statins. The main thing to know is when we look at randomized controlled trials, this is a study that collected a bunch of randomized controlled trials, and it looked at all the side effects of statins. We don't see an actual risk of all these side effects that are very substantial. They don't really reach significance. So serious adverse events, serious side effects, cancer, diabetes, myalgia, meaning like muscle pain, rhabdomyolysis, breakdown of muscle, ALT elevation, liver enzyme elevation. As you can see, they don't really break the line here in the middle. They don't really deviate from chance. So the most rigorous studies, randomized controlled trials, where you randomly give somebody one medication or a placebo or a different medication, you don't really see an increase in all these side effects. But the biggest signal is for the muscle stuff. So just keep that in mind, because you need to compare these risks with your benefits for cardiovascular disease and not dying of a heart attack. So let's talk about the new onset diabetes risk. Some studies show an increased risk when you have pre-existing factors. So if you already have obesity, if you already have high fasting glucose, if you already have visceral fat, a large waist circumference, if you're already in metabolic syndrome, then yes, you might have a slight increase in new onset diabetes. So in that case, if you're really worried about that, you'd want to think about moderate intensity statins. I would go towards moderate intensity statins over higher intensity statins, like rosuvastatin. However, even if there is a small risk, studies do show that the cardiovascular benefits far outweigh the metabolic risk. So for most people, that's going to be how they make this decision. You're going to prevent more cardiovascular events, more heart attacks than diabetes cases that come in. Because remember, you don't die of diabetes, you die of the consequences of diabetes. But you can die pretty quickly of a heart attack. What about muscle side effects? So atorvastatin, a moderate intensity atorvastatin, is probably the best you're going to get in terms of muscle tolerability. However, when you go to high intensity or high dose atorvastatin, you're going to have a higher rate of other stuff like liver enzymes going up, other muscle symptoms compared to rosuvastatin. So again, here you're seeing another theme. What matters is the intensity of the dose, sometimes more than the actual medicine you're on. So if you're worried about muscle tolerability and you're at moderate intensity, atorvastatin is what I would go for. If it's a high intensity treatment, I would probably go for rosuvastatin because it's lower risk. And overall, we see a 3% relative increase in muscle pain. So you see a little tiny signal, but when you do very careful studies, randomized blinded trials, we see an increase only in the first year from statins. And most of the muscle pain that's reported is what's called a nocebo effect. People are expecting this and they get the expectation side effects, or maybe they're exercising and they notice things a little bit more. But there is a signal, but it's not as big as people think. That's the key thing. Many people are afraid of statins because of this muscle pain fear, but it's much less of a concern for most people than they expect. And generally, there's no big differences between statins in terms of myopathy risk when you compare them in really high quality studies. There's a couple signals here and there, but overall, there's no humongous differences. So another variable is what other medications are you on? For people on complex medication regimens, I would think of atorvastatin as more desirable. And I would avoid simvastatin and lovastatin because they're going to mess with other things. So keep that in mind too. What else are you on? There are some absolute kind of contraindications too. So one thing to avoid is going on simvastatin up to 80 milligrams. That's actually no longer recommended by the FDA. It's a very high injury risk. So there are some absolute yes and no's. And for you grapefruit lovers out there, you got to avoid atorvastatin because you can increase toxicity levels of atorvastatin if you drink grapefruit juice. So that's an absolute thing to worry about. And we talked about East Asian ancestry with higher blood levels of Crestor, for example. So almost 100% increased drug exposure based on race versus European ancestry patients. Many patients also focus on the generic versus branded name of the medication. Don't worry about that. There's no difference in efficacy or safety. Generics provide the same heart protection, and they're widely available. Atorvastatin, rosuvastatin are widely available, and they're quite cheap now compared to many years ago. So if you're on a brand name version of these medicines and you switch to generic, you can save a lot of money. So think about that. So let's step back here and think about what kind of patient you are. Are you patient A? Maybe you had a prior heart attack or you have high risk. Of course, then you're going to need a maximum high intensity statin. What if you're patient B? Maybe you have a bunch of other medicines. You're on some aspirin, you're on some high blood pressure medicine, you're on a bunch of other stuff. Personally, if it was me, I would take rosuvastatin. It's often simpler, safer, fewer interactions. Or maybe like probably most of you, you haven't had a heart attack yet and you're trying to start something as a primary prevention because you read all this research showing how dangerous high LDL is. So in that case, if it was me, I would probably think of atorvastatin, moderate intensity. So here's my overall evidence-based ranking for selecting a statin. I think the overall default is atorvastatin or rosuvastatin as a generic. And remember, rosuvastatin is the most powerful. If you really need a reduction in LDL, that's the one that's going to provide the best benefit. Rosuvastatin is also the least likely to interact with other medicines, but the most studied one is atorvastatin, the longest clinical history. And if you go on one of these medicines and you have a side effect, remember, don't ever stop suddenly. Discuss it with your doctor. Most of the time, what I would do is I would go to every other day dosing instead of daily dosing to see if the side effect goes away. Make sure you're checking your lipids after a good 2-3 months on the medicine to make sure you're still getting benefit and you know what your trough level is. And here's the other thing. Sometimes doctors will not go off the statin entirely, but will back down on the dose. So for example, I might go down on Crestor from 20 milligrams to 5 milligrams, and then consider adding on something like ezetimibe, which is a great medicine to combine with a statin. So you can get some benefits of the statin still. You don't go cold turkey off of it, but you add Zetia to it and you get 2 types of benefits. So don't go all or nothing with side effects. Remember, the best statin is personal. You have to think of intensity, all of your factors, and what's going to make a difference in your life. All right, if you found this beneficial and you know someone with high risks for heart disease, pass this on. Let's try to help everyone we know with cardiovascular risk. Check out this other video, join my free newsletter for more deep dives and my own personal take on a lot of this stuff. Take care.